haven't had in the U.S. the supply of PPE to rapidly scale up around the country to provide the protection we want to provide.
That is Dr. Lloyd B. Minor discussing the current preparedness of the U.S. healthcare system for the COVID-19 pandemic. Dr. Minor says there are 3 principles that he emphasizes for preparedness.
I think there are 3 principles in addressing a crisis, and they're applicable for PPE. Are first, communication. Communication is absolutely critical in a crisis. Second is making sure that there's an understanding of roles and responsibilities. You want to have organizations that are very horizontal, but there's also a need to more succinctly define roles and responsibilities. The third principle is execution. In the end, successfully managing through and being able to meet the demands imposed by a crisis, it all feeds back to communications.
Dr. Minor is the dean of the Stanford School of Medicine. He reports that the response from his institution has been notable.
We're in a fortunate place, if you can use the word fortunate, in the sense that we early on had an FDA-approved diagnostic.
This is Medicine and the Machine, an information and conversational podcast about how technology is impacting medicine now and how it will in the future, featuring Dr. Abraham Verghese and Dr. Eric Topol. I'm a producer on the show, Nick Andrews. Today on the show, Dr. Abraham Verghese welcomes Dr. Minor to talk about crisis response, and in particular, the responses to COVID-19. Dr. Minor is the Carl and Elizabeth Naumann Professor for the Dean of the School of Medicine at Stanford. He is also a professor of otolaryngology and head and neck surgery. And now, without further delay, please welcome to Medicine and the Machine, Dr. Minor, and one of the hosts of the show, Dr. Abraham Verghese.
Lloyd, thank you so much for being with us. I'm truly grateful. And
thank you for inviting me to join you, Abraham. It's always a pleasure interacting with you, and I'm sorry that the circumstances are so difficult at this time.
Well, that's exactly what we'd love to talk about. Is we find ourselves in such a unique position in time. As I speak this morning, the latest data, the latest numbers that I have, and you probably have even later numbers, are that we have about 500,000 cases in the world with 25,000 deaths, 86,000 in the US, and 86,000 cases in the US, yes. And the hotspots in America are New York, New Jersey, and then California and Washington, D.C. But it's been so very dynamic. And I guess my first question to you is a personal one, and that is, you're the head of this massive enterprise to which I also belong. How have you been holding up with the stress?
Well, thank you. I have the privilege of working with amazing colleagues, an outstanding group of clinical department chairs and other leaders within Stanford Medicine and the university, and also outstanding leaders of our 2 hospitals. And we're working together very well. That energizes me. I feel very honored to be able to work with such incredibly dedicated colleagues, and that provides me with energy and resilience and sustenance. You and I have spoken before. I'm an avid reader, and I'm still trying to keep up with reading. There's no dearth of things to read associated with the virus, but also, and maybe this is something we could talk about today, Abraham, and in the coming days, and that is, what implications are there for the human experience coming out of this pandemic? I think the implications are going to be significant and long-lasting, but I've begun to think some about that, and perhaps even do some reading about previous pandemics and those effects on societies. I think very much as we come out of the current situation, how we come out of it and how we reaffirm our values will tell a lot about how we move forward as a society, first in America and then the world more broadly. So I've begun to think a little bit about that. I'm not going to the gym now because the gyms are closed, but I'm still trying to get exercise every day, and that helps a lot as well. But I'm holding up well, and it's because of the colleagues that I have the privilege of working with every day, and our mission. I mean, I think we all very much believe in our mission, which is to deliver outstanding patient care, but also to leverage the enormous intellectual and technological resources of this great university and to bring them to bear on this virus that we have so little understanding of. And we've already done a number of exciting things, perhaps we could talk about today in the research arena, and I know that there's a lot more to come.
Wonderful. Thank you, Lloyd. I'm sure that one day we'll look back and we'll catalog a history of what we did with this virus, both individually and as institutions and as a nation. But when you look at the milestones as you had to sort of gear up to this challenge, and the last month or several months, I would guess, but at least the last 6 weeks have been a succession of movements. What are the big milestones in your mind in terms of the evolving story at a major medical academic complex like ours?
I think one milestone was the realization when we started, we were one of the first clustering of cases in the U.S., the Bay Area. Now, we haven't grown as rapidly as New York, for example, and that has enabled us to scale up our delivery system in ways that's been a much greater challenge for our colleagues in New York to do. But when we started seeing cases, and in particular, we were one of the first to have an FDA-approved diagnostic for us to use in our delivery system. And that was approved in early March when our surrounding delivery systems were still having to depend upon local and regional public health departments, which rapidly those public health departments became overwhelmed. Therefore, because we were able to bring our RT-PCR online and use it in clinical testing early, we started to identify cases. And we saw that this was not just an isolated 1, 2, or 3 people where all the contact tracing could be done and all the appropriate isolation and separation for the work environment could be done for contacts. We saw firsthand that this was growing very rapidly, and that enabled us to get a start on the planning. And we stopped doing elective cases. We started, fortunately, we opened our new hospital in November, but we didn't tear down our original hospital. Therefore, we started thinking about, well, how are we going to bring beds back online, making staffing plans for that, making sure that we have adequate supplies of personal protective equipment. All this planning was able to begin several weeks ago now because we could see early on that this was not just an isolated 2, 3, or 4 cases that could be contained through traditional early stage epidemiological measures. And that I think has been a big help for us in responding. And we have not seen yet the surge in cases that has been seen in New York and was seen earlier than that in Seattle. We're prepared for it, and we still think there is a high likelihood we will see a surge, but it could be that the beginning of the shelter-in-place recommendations in the Bay Area now almost 2 weeks ago, the fact that many of the tech firms had already, even prior to shelter-in-place, had already told their employees to work from home. It could be that those measures are helping us to achieve a blunting or slowing of the growth curve in the number of infections in ways that it's been a challenge to obtain in different parts of the country.
I think one of the most fascinating things about what has just happened, is an unfortunate thing, is that even though we're very much a data-driven medical enterprise, a data-driven society, we've all been so hampered by the lack of data on the virus. I mean, to be able to do any sort of projections and not to be able to test people who are symptomatic, not to be able to know who was asymptomatic and infected, I think that's just been one of the most amazing things about this whole story, because we had the technology to get the data, but somehow as a nation, as a world, I don't think we were prepared. I mean, we had some warning, but even so, it's been amazing how the testing became such a bottleneck.
I agree with you, and I think there are a lot of lessons to be learned, and there will be a lot of analysis done and and writings made about the opportunities which were perhaps missed early on in terms of how we were prepared in the United States. But I think right now we have to focus on what we're dealing with in real time today and the future, and make sure that we're as well prepared as we can, and that we're delivering outstanding health care to the people in our region and in the world.
I know one of the challenges that you must be facing, I know you've been facing, is that you run a huge enterprise with many people, and people are subject to fears and emotions. And the downside to the digital age, I suppose, is that they also have access to all kinds of information coming from elsewhere. And I think you've had to deal with palpable fear and match that with what is reasonable in terms of resources when it comes to personal protection equipment and so on. Can you talk about how that whole scenario has evolved here at our institution, and maybe speak more generally about that whole issue of personal protection?
Yes, and in thinking about personal protective equipment and where we stand right now and how we plan for the future, I think there are three principles in addressing a crisis such as the one we're in today, namely the crisis of the COVID-19 pandemic and the implications of that crisis. And one of the most prominent implications is that we haven't had in the U.S. the supply of PPE to rapidly scale up around the country to provide the protection we want to provide. Now that's improving, but certainly it's hit us much harder than we were initially in the country prepared to deal with. So the three principles, and they're applicable for PPE, are first, communication. Communication is absolutely critical in a crisis. Second is making sure that there's an understanding of roles and responsibilities. Organizations oftentimes, when things are going well, you want to have organizations that are, particularly in academia, organizations that are very horizontal. And that character needs to be preserved in a crisis, but there's also a need to more succinctly define roles and responsibilities, because the third principle is execution. In the end, successfully managing through and being able to meet the demands imposed by a crisis, being able to do that successfully is dependent upon execution. So communications, and it all feeds back to communications. Communications, roles and responsibilities, and execution. So with those three principles, then how have we approached PPE? Well, communication, we began these weekly town halls. We had the third one, virtual town halls, which is somewhat unusual, speaking to 7,000 people, but actually having only 3 or 4 people in the room, namely the people making the presentations. But I think we're learning how to do it. Communication is absolutely essential. And yesterday's town hall was devoted entirely to PPE. And we had the vice president at SHC, who is responsible for supply chain, Amanda Chawla, talk about the supplies of PPE we have. She showed the graph. She showed our utilization rate, and really get information out about what we've received and what we expect we will be receiving. So communication is really important. Roles and responsibilities. We have a clinical operations resource team that meets every day, 7 days a week. We've expanded that team to add department chairs to the team, because department chairs, clinical department chairs, need to be able to relay back to their departments what types of decisions are being made, and also bring input from those departments to the decision-making body. Also, every morning, 7 a.m. on weekdays, 8 a.m. on Saturdays and Sundays, we have a call, a Zoom call with all the clinical department chairs, with hospital leadership, other key leaders within Stanford Medicine, where we give an update on everything that's going on. And people have a chance to express their concerns, give us feedback, but that communication is really, really important. And then finally, execution. We have gotten hundreds of people reaching out, wanting to donate PPE. We've tried to make sure that we respond to every single one. And so being able to look at and find new sources of PPE as we've done, to open new supply chains, to interact with state and local officials who have control over sources of PPE, that's all a part of execution. I think we're in much better shape than we were even a week ago in terms of our supplies of PPE. What is sobering about all of this is none of us knows exactly what our surge is going to be in our region. We know that the shelter in place is absolutely the best way to bend the curve on the exponential growth of infections of the virus. But how quickly will we be able to bend that curve, and then will we be able to sustain it over time? And this all plays into determining how much PPE we'll need in the near term and in the longer term.
So that leads me to talking about what we do best at Stanford, I would say, and that is cutting edge science. Stay with us. We'll be right back with Medicine and the Machine.
You can read the transcript from this podcast and find more Medicine and the Machine episodes at medscape.com/machine. Medscape news, features, clinical tools, and education are available for free. Stay on the pulse of medicine. Visit medscape.com.
That leads me to talking about what we do best at Stanford, I would say, and that is cutting edge science. What has this meant to the scientific enterprise, both in terms of impairing some of its ability to work, but also in terms of opportunities to do something about this? And I know that you've championed something that we're proud of at Stanford, which is precision health, the idea that we need to bring our great science to bear during times of health in order to prevent the sorts of diseases that now are the
scientists and engineers have really exemplified the Stanford ethos of thinking outside the box when it comes to the pandemic and the crisis at hand. We've received dozens of proposals from our faculty with novel ideas about how to do everything from 3D printing of devices and technologies that'll be beneficial in treating patients with the infection, to novel studies of the structure of the virus, to developing new therapeutics. We're in a fortunate place, if you can use the word fortunate, in the sense that we early on had an FDA-approved diagnostic, and we've tested, as of last count yesterday afternoon when I get the daily update, over 6,000 people. We screened with the nasopharyngeal swab screening for the virus, and we've identified the virus in a large number of people. And that biorepository now can be used to help us understand the virus much better than we have in the past. And we have a lot of faculty interested in doing that, as well as in really making this a focal point and Stanford a focal point for coordinating scientific studies related to the virus, its biology, its control, and its treatment of the infection in patients, making us an epicenter for that activity. And I think we'll see a lot more in the days and weeks ahead. The Stanford faculty are amazing. Our faculty are not attracted necessarily to incremental problems. And if there ever was a problem that was front and center and required really innovative thought and approaches, it is this crisis that we're in today.
That's wonderful. I want to just remind our listeners that you've really practiced in many different settings, from inner city Baltimore, where you were, the chair of ENT, and you were provost at Hopkins before coming here to Stanford to be dean. And you've covered a little bit of this, but what would be your advice for a hospital without our kinds of resources, sort of the experience that Elmhurst Hospital right now is having in New York, a hospital that's about to see this surge? What might you advise their CEO? And I know that you and our hospital CEO have such a wonderful relationship, something I've not really seen elsewhere work as well. So I think of you in the same frame as I think of our David Entwistle and the hospital administration. What would be your advice to a center without our kinds of resources, looking at this oncoming threat? You've addressed some of that, but what might be some advice you would give them?
Well, I think it comes back first to the three principles: communication, roles and responsibilities, and execution. And the first one is communication. And communication is particularly important when you're in the early stages of addressing a crisis and you don't have a game plan. I mean, you have a rough game plan, but it's not like you can lay out with a lot of evidence as to, okay, these are the things we need to do. And if we do them and do them well, then it's all going to be okay. This crisis, we're oftentimes still struggling with defining what we should be doing and also achieving any degree of certainty that if we do it, things are going to be okay. I think hospitals that are less resourced, then the most critically important resource for any healthcare system, whether it's an academic medical center, community hospital, large private system, the most important resource is our people. And people want to understand, they want information, and also information helps to address anxiety. There's a lot of anxiety and concern among the healthcare workforce in the United States today, which you can understand given the uncertainty of exactly how we know the virus is principally transmitted through droplet spread, but how long does it stay viable on surfaces? When do people need to wear N95 masks? We have some guidelines from the CDC, but those guidelines can be interpreted differently. So I think for systems that are relatively speaking under-resourced, still the most valuable resource is going to be the people, is and always will be the people, and making sure that there's good communication and input from as many people as possible will go a long way to helping everyone do the very best job they can with the resources that are available. And I think that's what we want to see in every situation.
That's wonderful. I want to turn in the last few minutes that we have to the fact that you have a great fiscal responsibility as a dean, and this is a very large enterprise that we run. What are the ramifications of this on the sort of fiscal solidness of all medical enterprises and enterprises like ours?
I think it's going to take weeks and months to understand the physical ramifications. The $2 trillion stimulus package that I understand was just passed by the House a few minutes prior to us beginning this recording of the podcast does contain some relief for hospitals and healthcare delivery systems. As to how that will actually help to financially patch the financial hit that we're all going to take, that remains to be seen. But at times like this, first and foremost, you have to focus on doing the right thing. We're fortunate in that for our hospitals, for University School of Medicine, we have had financial reserves. Undoubtedly, some of those reserves are going to be tapped into to get us through this crisis, but that's also the right thing to do. We already know that because we have ended all elective cases, we have intentionally reduced the inpatient census in our hospital in anticipation of a surge of patients with COVID-19, that has dried up or reduced a lot of our revenue streams. So there will be long-term ramifications from this. Those ramifications will initially manifest themselves in terms of our capital projects, what we were planning to build. I think it's reasonable to say, even at this early stage, that a lot of those plans are going to need to be reevaluated and planned over a longer time frame. But again, we absolutely have to focus on our people first and foremost. If we do right by our people, if we earn and sustain their trust, then I'm confident we can get through any financial hit that may come from this crisis.
Lloyd, as we wind down, can you share a personal anecdote of something that will stick in your memory long after this is over, that sort of reflects the triumph of the human spirit, if you will, or something that has lingered with you in these last few weeks?
Well, there have been so many things. I think hearing our colleagues speak up and express their desire to help, their support, their willingness to help us all work through this difficult set of circumstances. No one has backed away. Everyone has leaned in, and that's what encourages me every day, that we're going to make it through this, and that it is going to cause a lot of distress and a lot of human suffering, the virus that is, but we're going to get through this, and it's because of our strength and our people that we will get through it.
Lloyd, I just marvel at the weight and the responsibility that is on your shoulders. I must say, the last few weeks, just watching our town halls and, mini versions of that in every department and in every division, it almost seems as though we've been planning for this forever. And yet I know, and you know, that a lot of it has just been, good people coming together and doing the right thing. And it's just been so impressive to watch. I'm sure it's true of many organizations and hospitals around the country. I think the fundamental nature of the physician calling is that when the going gets tough, people do lean in and step in. We feel very, very privileged to have had you. I know you're busy every hour of the day. Thank you so much for being with us, and we wish you the very best in what you're doing.
Thank you, Abraham. It's good being with you, and thank you for your leadership and for the way you inspire every one of us, from what you're doing with Presence, from your writings. It's truly a privilege to be your colleague.
Thank you, Lloyd.